Hello, welcome everybody. So good to see so many of you join us this evening. The topic of the webinar will be on liver transplantation. My name is James Badman, and I'll be moderating the session this evening. Before we jump into the slides, I'm just going to hand it over to Helen to do a quick introduction. Over to you, Helen.
Thank you very much, James. I'm Helen Morment. I'm the Chief Executive here at AMMF, the cholangiocarcinoma charity, and a very warm welcome to everyone joining us for this evening's webinar on liver transplantation in cholangiocarcinoma. On behalf of all of us at AMMF, I'm delighted to welcome our esteemed speakers this evening, Professor Doug Thorburn, Professor Maria Hawkins, and Ms. Sally Fawkes, each of whom will be explaining the different and very complex aspects of what is involved for those with cholangiocarcinoma when it comes to the eligibility and preparation for transplantation, including the use of proton beam therapy. Unfortunately, Miss Anya Adair, who's also down as one of our speakers this evening, is unable to join us, as very sadly she's had a family bereavement, and we all send her our very kindest regards. However, very kindly, Professor Thorburn has offered to step in and give Miss Adair's presentation for us, as well as his own, and we're truly grateful to him for that. Joining the panel for discussion with the speakers will be myself and Paul Howard from AMMF, and we're also really pleased to have with us Mark Chatterley from PSC Support UK. So I'll now hand back to James, who'll go through some housekeeping for us, and then he'll ask each of our panel to briefly introduce themselves. Thank you.
Thank you very much, Helen. So as Helen said, I'll go through a couple of housekeeping slides just to get us going. In terms of the webinar, there will be a Q&A session towards the end. There is a Q&A feature towards the bottom of your Zoom. So please do get your questions in throughout the webinar. If you are experiencing any technical issues, there is a chat function. So please use that and a member of our team will help you. And then again, this webinar will be recorded. So please check out AMMF's website. It should be available in the next couple of days. In terms of the flow of the session, it will be 90 minutes. So we are currently working through the welcome and introductions. As Helen said, there will be 4 talks this evening. So just walking through it, the first one will be on an overview of liver transplantation in cholangiocarcinoma. So that will involve, who is now eligible and what is involved. We will then have a second discussion on protein beam therapy and why it may be used, importantly as part of the transplant preparation. We'll then go a little bit deeper into that and have a brief overview of the EMPHATIC study and what participation may involve there. And then the final talk will really bring it all together with a talk. And again, thank you, Professor Thorburn, for stepping in on the liver transplant process itself. So that will include the preparation, the procedure, and what to expect afterwards. After those 4 talks, we will then have a moderated discussion that will include all of our speakers. And then, as I said, we will have the Q&A for our audience at home. So again, please do get your questions in throughout. We will have time at the end where we'll work with our speakers to get them answered. Helen, I know you've just given an introduction, so if it's okay, I'll pass over to you. But Paul, would you like to say a few words?
Yes. Hello, my name's Paul Howard, and I'm AMMF's Head of Policy and Research.
Thank you, Paul. And Mark?
Hi there, I'm Mark Chatterley. I work for PSC Support. I'm the Head of Operations and Finance. PSC Support is the patient organisation in the UK for people who have primary sclerosing cholangitis. I'm also a PSC patient myself, and I had a transplant 2.75 years ago. It's old enough that I'm registering it in years now rather than months. It's a bit like a baby.
Brilliant. Thank you, Mark. Really appreciate your time. And then just moving to our presenters for this evening. First of all, thank you all for joining. It's great to have all of you here. I will start from left to right, if that's okay. So I'll start with you, Professor Thorburn. If you could give a quick introduction, including your title, name, institution, and your role.
So, hello everyone, I'm Douglas Thorburn. I'm a liver medical doctor at the Royal Free Hospital in London, and I'm the transplant lead for the pilot of liver transplantation for cholangiocarcinoma. Thank you.
Thank you. And Professor Hawkins.
Hello, everybody. It's really great to be here. I'm a clinician scientist, means I'm both a doctor and a researcher, and I focus to improve radiation treatment for patients with cancers of the gastrointestinal tract. I work in the hospital at University College London Hospital, and my research is at University College London. With Doug, we are both leading the EMPHATIC study with Sally's support. Thank you.
And Sally, that's okay for you to introduce yourself.
Yeah, of course. Hi, good evening, everyone. Thank you very much for inviting me to speak this evening. My name's Sally Falk, and I am the Proton Research Manager at the Proton Beam Therapy Centre at the Christie NHS Foundation Trust in Manchester. So wishing you all a good evening from a very wet and miserable Manchester, but I think it's a bit miserable everywhere in the country, isn't it, at the moment? So thank you.
Beat me to it. It's terrible everywhere. In London, rained all day. So thank you, Sally. And then just again, Anya will not be making it this evening, so Professor Thorburn will be stepping in. Thank you. On that note, I will hand it over to you, Professor Thorburn, for your first talk.
Thanks very much, James. And thanks to AMMF and to PSC support for supporting having this webinar. So let's hope it's of help to people. And next slide, thank you. Or do I? So cholangiocarcinoma is described based on where it is found within the bile duct. So it's a cancerous growth arising within the bile ducts, and it can be within the liver, intrahepatic. It can be in an area where the bile ducts join as they flow out the liver, which is called perihilar cholangiocarcinoma, or in the distal bile duct. I think it's missed off the slide. So that's in the area of the bile duct just before it reaches the gut. And about 2/3 are of the perihilar nature, and about 10% of them are within the liver. Next slide, thank you. And the management of these, wherever possible, is undertaken with curative intent, and that is usually surgical resection. In cases where it's not possible to resect the primary tumour, but the growth is of a relatively small size, transplantation becomes a potential therapeutic approach to treating the cholangiocarcinoma. So the two groups of cholangiocarcinoma where transplant is considered are small intrahepatic cholangiocarcinomas, the ones within the liver, and small perihilar cholangiocarcinomas in the setting of PSC is where the pilot EMPHATIC study is targeted. Next slide, thank you. The history of transplantation for cholangiocarcinoma in the UK was that around, and I'm not sure exactly the year, that there was a moratorium or they ceased to undertake transplant for cholangiocarcinoma, but it was in the early 2000s. And the reason for that was that the outcomes were unfavourable. There's a shortage of donor organs in the country, and when we undertake a transplant for a patient, need to expect an outcome of a greater than 50% survival 5 years after transplantation. And as can be seen here, particularly in the perihilar cholangiocarcinoma patients at the bottom, the 5-year survival was described as 30% based on the data up until the time transplantation ceased. And you can see that there was no benefit on the right-hand side of the slide of liver transplantation compared to resection in a series that came from Leeds, and that was based on 12 patients. So it was the case that transplantation for cholangiocarcinoma was not allowed in the UK. Next slide, thank you. But that's not to say that no patients were transplanted who had a cholangiocarcinoma. It was just the case that these patients were not transplanted intentionally. So in some cases, there was what's called the incidental finding of cholangiocarcinoma within the liver. And this is a series of almost 100 patients that were transplanted up to 2020 with incidental cholangiocarcinoma. And as can be seen, the results are fairly similar to the historic series that I described, and with 30% survival in the perihilar cholangiocarcinoma population. But what you can see below is that in those patients who had smaller tumours, T1 tumours, actually the 5-year outcomes were quite favourable, around 80%. So it looked like that in selected patients, it may be the case that transplant would offer some benefit. Next slide, thank you. So the practice of liver transplantation in the UK is overseen by the Liver Advisory Group, which is a subgroup of the NHS Blood and Transplant. And when new indications are under consideration for transplantation, there's a standardized approach to the consideration of those. And for many years, cholangiocarcinoma was thought to be an indication that should be revisited. And that's and these evaluations of transplantation for the new indications are generally undertaken for areas of practice where internationally acceptable outcomes after transplantation are identified. And the aim is to see if we can replicate that within a UK setting. So it's a service evaluation, it's not research. And there's numerous examples of where this has been introduced and led to a change in practice with the acceptance of new indications. Next slide, please. Thank you. There's a standardized approach to this, and it's quite a detailed and laborious process that can take a number of years. And the process of revisiting cholangiocarcinoma started probably around 10 years ago. So first of all, there's a group that goes away to make a recommendation as whether an indication should be taken forward, and that includes specialists across all areas of practice, including patient representatives. Their view is brought back to the Liver Advisory Group. If it's agreed the indication is taken forward, then a group is set up, the implementation group is set up to actually develop that indication and produce a protocol that would allow the pilot to be undertaken. And then there's ongoing monitoring once the pilot is opened, which might be just recording the data. There may be a national NDT or national oversight of the outcomes of the pilots. Next slide, thank you. So the working groups were established initially under Nigel Heaton's leadership, and then subsequently under Raj Prasad. Next slide, thank you. And it was just to show the range of expertise that was brought into the working group. So there's 7 adult transplant centres in the UK, so they were all represented. There's loads of acronyms there, but they're all the medical and surgical societies for HPV surgery and transplantation. And the radiotherapy and chemotherapy oncology groups were represented, as well as cholangiocarcinoma UK, which is a multidisciplinary group as well. So there was broad opinion sought in the development work. Next slide. Thank you. So what this has resulted in is 2 programs of transplantation, pilot programs. The first one opened roughly 2023 for very early intrahepatic cholangiocarcinoma. And initially, this was tumours that were up to 2 centimetres in size on the background of, in patients with a background of liver cirrhosis. it needed to be the case that the small tumour was not possible to resect the primary tumour, and that's because either the liver function was poor and the liver wouldn't tolerate having some of it removed, and the second was if the position of the tumour meant that it wasn't possible to remove it. And there were subtypes of intrahepatic cholangiocarcinoma that were excluded. Next slide, thank you. And the rationale for this was based on international evidence that was compiled from a multi-centre study, which showed that that was published by a surgeon from Toronto, which showed that tumours that were of this size, the very early intrahepatic cholangiocarcinoma group, gave favourable outcomes with a survival that was around 70% at 5 years and a low rate of recurrence at less than 20%, which is a rate that's accepted for other indications for transplantation that are for cancer indications. So that was why we came up with those criteria for this pilot. Next slide, thank you. And what happened over the subsequent couple of years is that the number of patients that were registered in the pilot were really quite small. Only 2 patients were registered in the first couple of years. And so the criteria were revisited. And in May of last year, these were revised, and the size of the tumour was allowed to be increased to 3 centimetres in size. It was possible to have treatment to maintain the size or prevent growth or try to shrink the primary tumour while they were on the waiting list. And it was possible for people to have prior systemic treatment that would not prevent them from being included in the pilot. So currently, most of the other criteria are the same, but the size has been increased to 3 centimetres. Next slide, thank you. The story of transplantation this is the patient pathway, and it's just to highlight that after the transplant assessment and patients are put on the list, the aim is to transplant them within 3 months, and if they're not transplanted at that point, they'll have further imaging to reassess the size of the tumour to make sure that it's within criteria to remain on the transplant waiting list. Next slide, thank you. The role of transplant for perihilar cholangiocarcinoma has been championed by the Mayo Clinic in Minnesota, and they identified these criteria for patients with cholangiocarcinoma up to 3 centimetres in size. And a key element of the transplant protocol was what's called neoadjuvant therapy. So this is treatment before the transplant. So a mixture of radiotherapy, brachytherapy, which is local radiotherapy, and chemotherapy as well. And before patients are transplanted, they continue on chemotherapy, but they undergo a surgical assessment to be sure that the tumour is still within the size that would allow transplantation. Next slide, thank you. And the evidence that they've accrued over almost 30 years of transplantation is that using these selection criteria, they can achieve very favourable outcomes. So overall, in almost 400 patients, it's a 75% 10-year survival, that's from the point of listing, but from after transplantation, the survival is 70%. So really remarkable results. Next slide, thank you. And what they also identified was that in patients with PSC, so if you look down in graph B, you can see in patients who have PSC, that's the blue line on the graph, that the survival is even better than those who do not have a background of PSC. And on the right-hand slide, PSC is in red, and transplant for cholangio in the absence of PSC is in black. And what you can see is there's lower rates of tumour recurrence and better rates of survival in those patients with PSC and cholangiocarcinoma. And that data really drove the way the practice has developed within the pilot in the UK. Next slide, thank you. And many centres around the world have now developed this practice. And what's been discovered is it's key to give this neoadjuvant therapy, because if you just do a liver transplant, even for these small and localized tumours, the outcomes are really not favourable. So it would seem that the neoadjuvant therapy is key to achieving these favourable outcomes. Next slide, thank you. So the current criteria for selecting patients with perihilar cholangiocarcinoma is that it's restricted to patients with PSC. The criteria are very similar in terms of the size of the tumour, but there is a need, unlike in the Mayo protocol, to have confirmation of the diagnosis by having a tissue diagnosis, usually from biliary endoscopy, ERCP. And it's really important that these patients have, that this is the first treatment that they've received, that there's no spread outside of the liver or into lymph nodes around the liver for patients to be allowed to be included within the protocol. Next slide, thank you. So it's just to acknowledge the enormous amount of work that's taken place over almost 10 years to get to this point in the programme. You'll hear more about the EMPHATIC protocol, which is the protocol for neoadjuvant therapy, but this really describes how we got to this point that we've started undertaking transplant again within the UK for cholangiocarcinoma. So thanks very much.
Thank you, Professor Thorburn, for that talk. We'd just like to remind our audience to continue to get your questions in for the Q&A towards the end. We are now going to head to Professor Hawkins to look at proton beam therapy. Over to you, Professor Hawkins.
Thank you so much, and thank you for everyone who's joined us this evening. So I'm just going to go straight to continue. So next slide, please. So I thought I'd quickly do a quick cartoon about the role of radiation in cancer treatment and just to explain, radiation works by damaging the inner core of the cell, specifically the DNA, and this stops cells from growing and dividing. Interestingly, the normal cell can repair the DNA damage caused by radiation. We give the radiation either via an external beam radiation or what we call internal radiation. And you heard already Doug mentioning brachytherapy. So we use a radioactive source which we insert in either the tumor or in a tube nearby. So the aim of the radiation is to cure the cancer and eliminate all the cancer cells, or to control the cancer to stop it from growing, or to help with relief symptoms. And usually we have quite a big team, and as the transplant team and the hepatologist team have, but the team we work with are physicists and radiation therapists. Next slide. So just going now to look at the role of radiation in cholangiocarcinoma, and I divide it sort of as a local or regional treatment or when there is metastatic disease. We're still learning when to use the radiation, but it helps with local control when there is, for example, biliary blockage or lymph nodes being in the vicinity involved. And we give it for palliation if there is bleeding or pain. And for today, we are just going to discuss a bit more about the role of radiation for transplant. So if you go to the next slide, please. I just wanted to mention that sometimes it's quite difficult to give radiation to the liver. So in the past, that used to be quite a big problem. Firstly, when we breathe, the liver moves up and down. Also, the stomach and the kidney is really close to the liver, and they are also very sensitive to radiation. If the treatment takes time over weeks. Also, the tumor is changing, shrinking, and sort of adapting to radiation. And to kill the tumor, to destroy the tumor, we need high dose of radiation. And some of this high dose, unfortunately, kill some of the normal cells. So if we go to the next slide, please. So we use radiation as a bridge to transplant, as Doug mentioned, this is sort of critical to get better outcome. And to repeat what Doug said earlier, as we develop these protocols over the years in the United States, the 5-year survival of the patients who are transplanted has significantly improved. So if you go to the next slide, please. So the Mayo Clinic protocol is what we call the gold standard. And this is also most widely used across not only the States, but in Europe. And is the basis, the protocol that's validated to be used for the United Network of Organ Sharing Policy. And as Doug mentioned, it's got some key components, which include radiation. And in the original Mayo protocol, the radiation was given as a combination of external beam radiation. And this is given concurrent with chemotherapy drugs, either an injection, an infusion, or a tablet. So the capecitabine is the tablet version of the infusion, which is 5-fluorouracil. And at the end of this sort of 5 to 6 weeks of radiation, intra sort of biliary duct radiation was given with radioactive wires or seeds to give more dose to the tumor. And while the further assessments are in preparation for the transplant, more systemic chemotherapy is given, and this is usually continuous until the time of transplant. And it's a combination of 2 or 3 drugs. Next slide, please. So over the last decade, there have been a lot of technical, not only hardware, but software advances in radiation. So we have methods to manage the way patients breathe so the liver doesn't move so much. And we also have image modalities. So we have what it looks like a CT scan just 30 seconds prior to giving the radiation. We also have computer and AI-driven ways of visualizing how to deposit the radiation to focus on the tumor and spare the normal tissue below. And in the UK, in the last 5 years, we have two proton center. But yeah. So next slide, please. So there is these 2 types of radiation, what we call external radiation. And this is a cartoon I've taken from the CIUK website because to me it's really clear what the difference between the 2 ways of delivering the radiation is. So the photon beam or X-rays are very small packets of very high energy. And as this high energy travels to reach the tumor, it's sort of the energy sort of decreases as it reaches the tumor and then continues to travel and decrease in energy after hitting the tumor. The protons are small particles and they are very high energy though, but we can now have the technology to control these high energy particles to stop where the tumor is. And where the protons stop, all the energy is delivered. So in that way, there is no sort of energy traveling further from the tumor, but also there are significantly fewer cells damaged with this radiation. In terms of the effect, the effects of both X-ray and protons are the same. Next slide, please. And this is a picture of the proton beam therapy machine we have. So the Christie machine and the London, so University College London Hospital machines are identical. So if I ask Sally to guess where this machine is, she can't because the rooms look the same. But what you can see that black sort of thing, it's the treatment couch, which is on a KUKA robot, which is a robotic arm that it's used in the industry to move things around, so it can move quite a lot. And at the top, there's this sort of funny looking thing, which is got like two flaps. That's where the proton beam comes, and that moves around the machine and the robot. So next slide, please. So this is an example of radiation treatment to liver. So I'm just going to start on the left-hand side. So you can see it's on this gray sort of triangle, it's saying liver. There's a big red splodge with some blue lines around it. The red spot is where the tumor is and where we put a lot of radiation. The left-hand side is a proton plan, and you can see we can spare the liver quite a lot. The blue is where the radiation proton beam comes in. It stops in the tumor. So we've got two proton beams, one from side and back. On the right, it's an X-ray of photon radiation plan, and you can see there's a lot of low dose. So the blue is low dose of radiation, which is the radiation that fades out as it leaves the tumor. And the other thing you can see, this orange, yellow, and green area is medium dose of radiation. There's also more medium dose given to the normal tissue, specifically the liver. So the reason we selected proton beam was to spare the normal liver, especially we know that in patients with primary sclerosing cholangitis, the liver might be already sort of a bit stressed by the pre-existing disease. Next paragraph. Next slide. So I've got, and what evidence did we use to justify the use of proton beam therapy? In 2016, there was a multi-center study undertaken in the United States in which both cholangiocarcinoma and hepatocellular carcinoma patients were treated with proton beam therapy. They received 15 fractions to 67 gray. So that's the dose we've selected to use. And they had some key eligibility criteria. If you go to the next slide, what was really striking from this study, despite here tumors up to 12 centimeters being treated, there was very little liver or other toxicity. Only 4 out of the 100 patients had toxicity, and there was no one who had severe toxicity or died from the treatment. If you go to the next slide. So this, as I said, the combined patients, hepatocellular carcinoma and intrahepatic cholangiocarcinoma. The yellow are the cholangiocarcinoma patients. So you can see we had, with the addition of proton beam therapy to chemotherapy, there is very good survival. These are patients who are inoperable, so a different group of patients, but there was evidence that there is good local control and survival by the use of proton beam therapy. next paragraph. So this is the basis of our study, and that's why we use proton beam therapy. And we replace the brachytherapy in this study with proton beam therapy boost, so we can ask the computer to give more dose to the area where brachytherapy would have been given. In the UK, we do not have the expertise or technology to give brachytherapy in the liver, and we agreed that this would be a more elegant and convenient way of giving a boost to the tumor, and achieve the same effect in terms of radiation dose. So this is my last slide, which I think sort of opens the hopefully the podium for the next speaker. Thank you.
Thank you, Professor Hawkins. And yeah, I completely agree. It's a really good segue into Sally's slides this evening. Over to you, Sally.
Thank you very much. Next slide, please, James. So good evening, everyone, again. So I'm going to be talking to you about the EMPHATIC study and what's involved for patients receiving PBT as part of their workup for transplant. So EMPHATIC is also known as ABC13. That stands for the Advanced Biliary Tract Cancers, and it's a portfolio of trials and studies that have been going on for many years, and we've added ourselves to that. EMPHATIC itself is the evaluation of combined modality protons and hepatic transplantation for hilar cholangiocarcinoma. And it's a study within what we call EKIP, which is the Evaluative Commissioning in Protons Programme. And EKIP is a programme looking at new indications for protons or refining current indications where a randomised controlled trial is not feasible, for example, due to the rarity of the cancer, lack of funding, or a lack of clinical equipoise. Next slide, please. Bit of background for you. So EMPHATIC, we're looking to see whether a combination of treatments, including PBT, chemotherapy and a liver transplant, can be used to treat patients with cholangiocarcinoma. The current standard curative treatment option is surgery, which may be followed by chemotherapy. If the cancer can't be removed with surgery, i.e. it's not resectable, then standard current treatment currently involves chemotherapy and immunotherapy. This is not a curative treatment option, but aims to control the cancer. The EMPHATIC study offers certain patients with primary sclerosing cholangitis who develop cholangiocarcinoma that is unresectable, a potentially curative treatment option. Next slide, please. There's evidence that liver transplant is a curative treatment option. Patients are placed on the liver transplant waiting list until a suitable transplant is available, but there is a risk that the cancer may grow or spread whilst waiting for a transplant, potentially making patients ineligible. PBT and chemotherapy is thought to be the best way to control the cancer until a liver transplant can be performed. And EMPHATIC is looking at how a combination of PBT and chemotherapy, followed by liver transplant, can be used to curatively treat PSC patients who develop unresectable cholangiocarcinoma. Next slide, please. So a little bit about the study design. Thank you. The primary objective is to assess the safety and feasibility of neoadjuvant chemo-PBT and liver transplant for adult patients with perihilar cholangiocarcinoma. Primary endpoints are the number of significant side effects up to 90 days following completion of chemo-PBT and liver transplant. And we're looking at the proportion of patients who, following chemo-PBT, undergo a successful liver transplant measured at 90 days post-transplant. Next slide, please. So this is just a quick schematic of the patient pathway. Maria's last slide was a more complicated version, but this is just a bit of a pared down version. So basically, for the study, patients will be identified at the transplant centre as possibly eligible. And if they are interested in taking part, they'll be referred to the PBT centre. They'll come to us for a first visit, which we call either a single assessment or planning visit. At that visit, the patients will meet the team, they'll consent to the study and consent consent to treatment, but most importantly, they'll have their planning scans. So this is CT and MRI scans, which are then used by our physicists and clinicians to plan the radiotherapy treatment. After 2 to 3 weeks, patients will return to the PBT centre to have their treatment. This treatment is 15 treatments over the course of 3 weeks. Ideally, it'll be a Monday to Friday over 3 weeks. And at the same time, you'll take a chemotherapy tablet, capecitabine, on the days that you would have the radiation therapy, and weekly checks with the doctor. After 4 to 6 weeks post-PBT, patients will go back to the transplant centre to be reassessed, and if at that point they're still eligible, they'll be added to the transplant waiting list. At this local cancer centre, they can have up to 6 cycles of chemotherapy, so IV chemotherapy, whilst on the transplant waiting list, and then hopefully, all being well, progress on to liver transplant. The study data is collected and managed by the Proton Clinical Outcomes Units at the PBT centres. Next slide, please. To be eligible for the study, participants must be aged 17 and over, fit, active and able to tolerate treatment, suitable for a liver transplant as determined by a multidisciplinary team, have a history of primary sclerosing cholangitis, presence of a high stricture or mass measuring less than 3 centimetres, have histologically proven cholangiocarcinoma, and they mustn't have any metastatic disease, so the disease shouldn't have spread anywhere else in the body, including to the lymph nodes. Next slide, please. So on to proton beam therapy. So Maria's already talked a bit about the differences between PBT and regular radiotherapy. So hopefully my little section won't be too repetitive. But proton beam therapy is a type of radiotherapy. Protons are small particles found in the middle of atoms, and they can be used to give carefully calculated doses of radiation to treat cancer. This is different to standard radiotherapy, which uses high energy X-rays or photons. Protons release their energy at an exact point in the body, which means that the dose to the tumour can be given very accurately, and there is little or no dose to the normal tissue past the tumour. PBT is a national service. There's 2 PBT centres in the country, in the UK, one at the Christie in Manchester and one at UCLH in London. Next slide, please. So I've got some nice pictures here, which will probably make you understand when you look at the size and scale and complexity of the kit, why there are only 2 PBT centres. So hopefully you can see this okay. It's a bit small on my screen, but we start on the top left with the circular bit of kit, which is the cyclotron, and this is a particle accelerator. So using electric fields, the cyclotron can accelerate the hydrogen protons to 2/3 the speed of light. Electromagnets then focus and route the proton beams to the gantries. And you'll see there we've got 3 gantries, and these are, each of the 3 gantries is 3 stories tall and weighs 200,000 pounds, which is over 90,000 kilograms. I don't know if you can see, but in the first gantry, the one closest to the cyclotron, there's a little tiny red patient there, so you can sort of give you the context of the scale and the size of the machinery. On the top right, this is what's an actual picture of what the cyclotron and the beamline and the magnets look like. So there's lots of wires and tubes, and we do have teams of engineers on site all the time. These are from NHS engineers and also from Varian, who are the manufacturers of the equipment, and they are on site all the time to ensure that the kit moves, continues to work. There's a lot of moving parts there. Maria's already shown the kind of front of house picture. So this is bottom left is what you would see as a patient, and Maria's right, this is our machine. Looks completely the same, our gantry. So PBT is given using a machine called a gantry, which can rotate through 360 degrees, means it can accurately aim the proton beam to the area needing treatment. And proton technology in the UK offers pencil beam scanning on each gantry, and this means that it uses a narrow beam of protons to move back and forth across the tumour site at a range of energies to meet the required depth of the tumour. Next slide, please. So patients are treated lying flat on the back with standard immobilization and motion management techniques. So Maria's already mentioned that the movement of the internal organs is a problem in delivering very accurate radiotherapy. So the point of immobilization and motion management is to keep patients as still as possible for treatment and their anatomy in the same position for every treatment. And we use a couple of different things. We use something called vac bags, which are like bean bags that the patient would lie on, and then these have been molded to the body and fixed. So that you're in the same position every treatment. Also makes that very uncomfortable bed a little bit more comfortable. And also we could use a compression belt, which is like a leather belt with a pouch at the front where air is kind of pumped in, just to kind of keep the internal organs a bit more still and in the same position. PBT is delivered, as we've already mentioned, in 15 fractions or 15 treatments daily on weekdays over a period of 3 weeks. And each treatment lasts about 45 minutes. About 30 minutes of that is setting up the patient, so getting patients in the right position, taking some pictures to make sure that the anatomy is in the same position for each treatment. So probably only about 10 to 15 minutes is the actual delivery of the radiation. And PBT is given with concurrent standard capecitabine, that's oral chemotherapy, taken twice daily on radiation days. And for patients who don't live near to a PBT centre, accommodation in apartments is offered for the initial planning visit and for the duration of treatment. Next slide, please. After PBT, and reassessment for transplant, patients will be considered for up to 6 cycles of standard 3-weekly chemotherapy. The most commonly used standard chemo regime is cisplatin and gemcitabine, and these are IV chemotherapies given on day 1 and day 8 of a 21-day cycle. Chemotherapy regime may change based on the standard of care, and adaptation to the regime for individual patients is at the discretion of the treatment team in line with best clinical practice. Next slide, please. Liver transplant will be undertaken at one of the 7 UK liver transplants. The clinical care around liver transplantation is standard of care and is not considered to be an experimental part of this research protocol. Detailed information about liver transplant is provided to EMPHATIC study patients by the transplant centre. So as Doug mentioned, there are 7 transplant centres in the country, and I've just split them up here. So patients who come from the Royal Free in London, King's in London, or Addenbrooke's in Cambridge would go to UCLH to have their proton beam therapy, and patients from Queen Elizabeth in Birmingham, St James's in Leeds, Freeman Hospital in Newcastle, and Edinburgh Royal Infirmary would come to Manchester. Next slide, please. In terms of study follow-up for EMPHATIC, follow-up includes proton clinical outcomes standard follow-up time points, which every patient having protons is followed up at a specific set of time points, and that is end of treatment, 6 weeks, 6, 12 and 24 months post-PBT. We have an additional 3-month post-PBT follow-up time point, and if patients undergo liver transplant, 90-day post-transplant information will also be captured. Follow-up can be either face-to-face during clinics if patients live locally to the PBT centre, or we also offer the options of telephone and video calls with the PBT clinician if you don't live nearby, and this will be supported by research radiographers at both NHS PBT treatment centres. Next slide, please. Oh, this is my last slide. So this are just some contact details if you wanted to get in touch with myself. That's me and Faye, who's our research radiographer at the Christie. UCLH also have a research radiographer, Ria. So yeah, please feel free to contact us if you have any questions. Thank you very much.
Thank you very much, Sally. We are now going to head over to Professor Thorburn again, who's kindly stepped in for Ms. Adair. So over to you, Professor Thorburn. I'd also like to flag that there will be some graphical images as part of this presentation, so some of you may find them sensitive. Just wanted to flag that for this talk, but thank you again, Professor Thorburn.
No problem. Anya's the surgical transplant surgical lead for the protocol and the pathway. So and yeah, she's very sorry she's not able to join us tonight. Next slide, thanks. So when it comes to having transplant, this pathway that we've described is pretty complicated version of a standard transplant pathway. Generally, we undertake liver transplant for people who we're looking to extend their life. So generally, it's used as a treatment to improve the anticipated survival of people after a liver transplant. In a small number of people, it's to improve their quality of life. They might not be likely to die from their liver condition, but the quality of life might be so poor that going through a liver transplant is deemed an appropriate approach to the condition. And there's three main categories of patients. There are people that have got liver failure. Their liver isn't doing the jobs that it's meant to do, and that is associated with shortening of people's lives. Selected patients with cancers other than cholangiocarcinoma, so generally hepatocellular carcinoma. And then there's some people that have been previously fit and well and suddenly develop an acute form of liver disease and get very unwell over a short space of time and are not deemed to be likely to recover from that. And in those patients, we would think about liver transplantation. Next slide. Thank you. So I think I've covered most of this, but there's a whole range of conditions that could put you into a category of patient where transplant would be suitable. And as it says at the bottom, aim is predominantly to improve survival and give a cure from the underlying liver disease. Next slide, thank you. The pathway is getting referred to one of the transplant centres, an assessment's undertaken, added to the transplant waiting list, and then at some point thereafter, average of about 6 to 9 to 12 months, depending on the some of the characteristics of the recipient, and then ongoing care after transplant, which these days is generally undertaken in a hub and spoke type of model where people are cared for as close to home as possible in a linked up way with the transplant centre where they've been transplanted. Next slide, thank you. So the referral can come from a liver doctor, from a liver and bowel doctor. It might be a cancer is found and they go through a cancer MDT. And assessments are generally now undertaken in a combination with the local centre and the transplant centre, mostly on an outpatient basis, and can last two or 3 days. Next slide, thank you. The question that the team are asking themselves when somebody is being assessed for a liver transplant is there a clear indication for transplant? So is this the right time to consider transplant? Is there any medical treatment that could be offered that would improve the outlook for that patient that would mean transplant wasn't necessary? Are there any reasons that a transplant couldn't be done safely? And is the patient fit enough to get through it? And what does the patient, once they've heard about the process of transplant, and would this be something that they would be wanting to accept? And some patients say this isn't a treatment that I would be willing to accept, and that's very informative. Next slide, thank you. And there's a standardized assessment process, and we've got a nationally standardized assessment process, which is a combination of a number of investigations to assess the severity of the liver disease, the overall fitness of the patient, but also a number of assessments from doctors, nurses, the medical anaesthetists, and allied health professionals to determine need and suitability for transplantation. Next slide, thanks. And this may include some assessment of cardiopulmonary fitness. So this is one form of assessment. It might be a treadmill test. Some centres run patients up and down stairs. But the key message is that people have to be physiologically fit enough to go through what is a major undertaking as a surgical operation. Next slide, thank you. And when people are being assessed, consideration is given to what kind of donor organ would be suitable for them, but also the patient is given the opportunity to consider and consent themselves for specific types of donors. And they're listed here, And in the UK, there's a real drive again to try and develop live donor liver transplantation, where a close friend, relative, etc., would offer a portion of their liver to be transplanted into the patient who is waiting for a transplant. And from a deceased donor, it could be a whole liver or it could be a part of a liver, depending on factors associated with the patient at the time they go onto the list. Next slide, thank you. So when people are on the list, they're reviewed regularly, either in the transplant centre or at the local centre in collaboration with the transplant centre. Almost all the transplant centres have got psychological support for patients now, because, of course, it's a very uncertain time. During the waiting, people are concerned that things will progress while they're waiting, and it's uncertain when a transplant might take place. So it's a very burdensome experience being on the transplant waiting list. And there needs to be interval reassessment, particularly for patients with cancer indications, to check that the growth is still within criteria that would allow transplant. And also there may be treatments that are offered while they're on the waiting list to try and prevent the growth in the liver from enlarging. Next slide, thank you. So this shows a liver that's split. We know that there are insufficient donor organs for us to transplant all the patients that are now waiting the waiting list. There's over 600 people waiting for transplant. And so various approaches are taken to try and increase the donor pool to maximize the number of patients we can transplant. One approach is splitting livers. Usually the left lobe, which is the smaller triangular lobe, is given to a child or to an adult that weighs less than about 40 kilograms. And the right lobe of the liver can be transplanted into an adult patient. But the liver needs to be big enough that it can be split, and the recipients need to be small enough that they can accept a reduced size of graft and fit enough to get through that operation. Next slide, thank you. There are other approaches now that are being rolled out nationally to try and increase the ability of the centres to utilise donor organs for transplant. And these are techniques that are supported by machine perfusion, and these can be machine perfusion in the donor, and that's NRP, or they could be machine perfusion of the donor organ once they get back to the hospital where the transplant is going to take place. And that could be hypothermic, meaning that the liver is cooled, or normothermic, meaning that the liver is kept at body temperature, and blood and oxygen is circulated through the organ to try and maintain the health of it until such times that it's transplanted. And that provides the opportunity to assess the function of the graft, and maybe even to optimize the graft by offering treatments to the donor organ to try and improve its function. Next slide. So these are the sort of approaches undertaken to try and increase the donor pool. In terms of the operative procedure, I say I'm a physician, but I do my best to describe the stages. Retrieval is when the surgeons go to retrieve the donor organ from the donor. These days, it's often one or two consultant surgeons that are having to go out on the retrieval. Once the organ gets back to the hospital, it's taken to the back bench. So it's then prepared for implantation. At the same time, the patient who's having the transplant is undergoing an operation to remove the donor organ. And once that's done and the liver for implantation is prepared, the transplant itself takes place. Next slide. And I think we can probably move quite quickly, but this is when it's in the back bench and being prepared for implantation. Next slide, thank you. And this is what a theatre looks like in the midst of a liver transplant. You can see it's a bit blurred because some people are moving quickly, and some people are incredibly still, wearing what's called loop surgical glasses so that they can see the very small blood vessels that need to get connected. Next slide, thank you. Just click through. So this is what the scar looks like after the operation. This is where the new liver sits within the abdomen. Next slide, thank you. And this is just to show the sort of how the liver is implanted. So what's connected up are the blood vessels that drain the blood out of the liver, the blood vessels that carry the blood into the liver, which are the hepatic artery and the portal vein, and then the bile duct, which is where the bile comes out of the liver and goes back into the gut. So it's a bit like, and if this is being recorded, but it's a bit like plumbing in a washing machine. You have to make sure all the pipes are connected up in the right way to ensure that the best outcome can be achieved. That sounds very simplistic, but it's the skill of the surgeon is to do that in a way that's safe and delivering the optimal outcomes for the patients. Next slide, thank you. Keep going. I think there's a few pictures that come in, but this just shows there's other aspects in terms of how the bile duct is joined up. The bile duct can be joined back to the stump of the bile duct, but in the image on the right, you can see there's a loop of bowel that's brought up to be attached to the bile duct. And indeed, in patients with cholangiocarcinoma, that would be the standard way that the bile duct is reattached to the gut. Next slide, thank you. And then after the operation, the patient gets taken to the intensive care unit. They might be woken up, they might have the tube, they might not need to go back on a ventilator on the intensive care, but the average stay in the intensive care after the transplant operation is 1 to 2 days. And there's a number of tubes that are connected to the patient after the operation, which are critical to ensuring a good outcome is achieved. And there's very close monitoring for the first few days in the intensive care, and even once they go to the ward, to ensure that the liver is functioning normally and that all the connections between the liver and the recipient are have been undertaken in a way that no complications will arise. Next slide, thank you. So the specifics of transplant for cholangiocarcinoma. Next slide, thank you. We've talked a bit about this already, but it's about identifying the right patient for consideration of transplantation, and mostly that will come through the cancer MDTs, either in the transplant centre or across the HPV centres across the UK. And the key thing is making the diagnosis, staging it, and ensuring the patient has been put forward to the transplant centre for consideration in a short time window such that transplantation can be undertaken. Next slide, thank you. The radiological assessment of high-low cholangiocarcinoma is quite complicated, and this just to give you a kind of view of the assessment that needs to take place at the point where the patient is put onto the list, but also after the neoadjuvant therapy that we've heard about within the EMPHATIC protocol, and during the time that they're waiting again on the transplant list. And there also has to be endoscopic assessment of the tumour, which includes taking biopsies to confirm the diagnosis, and also to be sure that there's no lymph nodes that are involved with the tumour. Next slide, thank you. So yes, I've covered this. So there's it's really important that the tumour is fully assessed to know that it is within criteria, that the diagnosis is clear, and that's why a tissue diagnosis is required. But it's also critical through cross-sectional imaging, but also through endoscopic assessment to be sure that the tumour is small enough to be within the criteria that would allow transplant. Another aspect that's unique to considering transplant for cholangiocarcinoma is trying to get the jaundice that is often accompanied by the diagnosis of cholangiocarcinoma treated to the point that the EMPHATIC protocol can be delivered, and we can take them through this, but also to try and keep the patient fit and well nourished while they're waiting for transplantation. And there are two things that are somewhat unique to the cholangiocarcinoma and the PSC population. Next slide, thank you. And I think I've covered everything.
Yes, thank you. Thorburn. I will now ask all of our panelists and speakers to put their cameras on. Welcome back. First of all, lots of great information there. Mark, Helen, and Paul. Any questions you'd like to put to our speakers?
Well, I'd like to come in with one immediately, if I may, James. It's Helen. And this is really to Professor Thorburn. We've talked an awful lot, and necessarily so, tonight about one arm of the current transplant situation for those with cholangiocarcinoma, and that's those with the perihilar cholangiocarcinoma who also have PSC. And these are the ones that we've talked about, the workup protocol, which includes proton beam therapy, which is the first time this has been used in this sort of setting. So that's why that part is a study, and we have the EMPHATIC study, which both Professor Hawkins and Sally have described incredibly well. But could you just, and I know you did it at the very beginning, but could you just explain once more, what is the workup to transplant? What's the protocol for the other arm, those with the intrahepatic cholangiocarcinoma, for which if they have another sort of chronic liver disease as well, like a cirrhosis, and then they developed an intrahepatic cholangio, we know it has to be smaller than 3 centimeters. But what's the workup to transplant protocol for them?
Well, the first thing is to make the diagnosis, and that would normally be through the HPV, so the surgical HPV cancer MDT, and as I said, that in terms of treatment with curative intent, the first option to be considered would be surgical resection. And it would only be those cases where surgical resection is not possible due to the severity of the underlying liver disease, meaning that the patient couldn't afford to have the tumor and some of the surrounding liver removed, because that would likely be a fatal thing for them, or technically it was not possible to resect the tumor. Because of the position that the tumor sat. It's then important that there's confirmation that they have background liver disease, that there is histological confirmation, so a tissue diagnosis that confirms it's cancer, and it's not poorly differentiated, and it's not a mixed type of cancer, that there's no blood vessel involvement, which would again large blood vessel involvement, because again that would contraindicate liver transplant. And if all those criteria are met, and it's less than 3 centimeters in size, then it would be feasible to consider those patients for transplantation. We're not allowed to so-called downstage patients into these criteria, so the tumor has to always have been less than 3 centimeters. But if they do meet the criteria, it's possible to give them treatment to the tumor directly to try and prevent it from growing, to keep them within the criteria that will allow us to transplant them for as long as possible, to provide a window to deliver transplantation. Does that address the question?
Well, it does. So really, there's no radiotherapy of any sort necessary for them. It's the eligibility side of things is the strictest bit. They don't have to go through a pre-treatment protocol like the others do.
There is no pre-transplant protocol that's proscribed for those patients. The centre may decide that it's in the patient's best interest to have treatment that will prevent it from progressing, but that's not a requirement. It's an optional consideration based on the individual characteristics of the patient.
Okay, thank you for that. Thank you.
And Mark, I'd be interested interested to hear from you. Obviously, you've had experience with the transplant. So, any questions?
Yeah, so I kind of want to draw two things together, if that's okay. I mean, first, I really want to say thank you to all of the incredibly clever people who have made this happen and brought this together. Going back to, I mean, there must be massively clever engineers who've created those huge machines. Those were very impressive slides to see how big the machines were. So thank you to everyone who's made this possible, because PSC patients, we know a lot. We know a lot of PSC patients. Google, I certainly did. People out there, and the information's out there, and we know all the scary stats around PSC, that we're 400 times more likely to get some form of cholangiocarcinoma than the general population. We know there's sort of a 20% lifetime chance, and they're really scary statistics. And up until now, we've been sat kind of jealous of other countries, namely America, but even countries as close to us like Ireland, who have transplant as an option if you got diagnosed. And so now we've got a route in, and that's really important to patients. So I just thank you for bringing this all together. But I was also wondering, we know that, I think, Doug, you said it, that livers are in high demand. That's why we're looking at things like split livers and different options and all the perfusion technology. But would you be able to mix the trial up, this transplant proton beam therapy, with potentially a live liver donation?
The key thing is to get the patients transplanted in quite a short period of time after they go on to the waiting list, because while these treatments that we've heard about, proton beam therapy and chemotherapy, are to kind of hold things in check, or even potentially to make the growth shrink. The longer that the patient waits for the transplant, the increased chance there is that the growth will progress. So the key thing for both categories, the intrahepatic and the perihilar cholangiocarcinoma patients, is to transplant them, and we set out to transplant them within a 3-month window of going on the list. In an ideal world, we would have plenty of optimal donors that we could transplant patients with, but unfortunately that isn't the case. We now see really excellent outcomes after transplant with what historically would have been considered more marginal grafts, so more challenging grafts to use. So it's been generally agreed that we should consider any type of graft that would be suited for these patients. Live donor is certainly one of those options. There are certain challenges around the timing of that, the timing of the workup, etc., and technical aspects of that. But the answer is not no. It would be that we would encourage relatives to come forward. We would certainly consider it. There's a national program to redevelop live donor liver transplant within the UK that have a proctor team to support centres to develop build their experience and independence around live donor, which has resulted in a really cohesive and collaborative and excellent approach to live donor liver transplantation. So there are the means to consider it. I think it just would have to be considered on a case-by-case basis.
Makes perfect sense.
Professor Thorburn, if I could just come back on that, it was really excellent question from Mark, and it was one of the ones that was on my mind. But you've mentioned a few times that the optimal time to transplant these patients is within 3 months. So when somebody is deemed suitable for transplant, and bearing in mind we all know how cholangio can progress really quickly, do they go on? Is there an urgent list they go on? I mean, are they considered in need of a liver urgently? Because we know there's lists and big demand for livers.
Yeah. So there are ways that there's now standardization of liver, the way that livers are offered nationally for the DBD donors. the DCD donors are offered to local centres. So there is a process of prioritization of these patients nationally, with a view to trying to get them an offer of a transplantable liver within 3 months of going on the list. But that's very dependent on, what's going to happen tomorrow and the day after. So there's no guarantees around that, and there's therefore a requirement for the centres to try and increase the pool of organs they might be able to use in transplant for these patients. So these patients will be, they're not going to be so many of them. We think there'll be 30 patients transplanted within the programme. I don't think we've explicitly said, but part of the reason that this has been set up as a trial and a commissioning evaluation is if we can show that we can deliver this as a programme nationally, and reach the endpoints of the EMPHATIC and have good outcomes after transplant, there is the possibility that this could become routine care in the future for patients. So it's really, there's quite a lot riding on the success of this pilot. So, centres have got relatively small numbers of these patients. The EMPHATIC's been open since October, and there's a real focus on trying to get these patients transplanted in a short period of time. But we've got one way of operating the waiting list for elective patients, and they are given quite significant priority within that, but they're not prioritized higher than some other people that will succumb within a day or two if they don't have a transplant. So it's a zero-sum game. We've got to try and use the organs to meet the needs of the entire population that are requiring transplant.
Thank you. Helen, I think obviously we're running a little bit behind. I would like to ask questions if it's okay.
Yes, we have quite a few, don't we, popping in?
Yeah. So we will move to our audience questions now. Thank you everybody for sending them in. I would just like to flag that the ones we don't get to this evening, we will follow up offline. Sally, I will come to you first, if that's okay. I mean, Mark gave a good sound effect with the machine, but we've got a question. Does the kit make a noise like MRI scans, or do you have to breath holding like with MRIs of the bile ducts?
Thanks, James. Yeah, I think there's two questions there. So does the kit make a noise? I think yes, when the gantry is rotating to get into position, that makes a noise. I think I don't think it makes a noise when the protons are actually being delivered. It's just when the nozzle, the head of the gantry is moving. That's quite loud. And I think it's a separate question about breath hold. I'd have to check with Maria. I think Maria might have mentioned under one of her motion management techniques that breath hold is used. Can I just confirm that with you, Maria?
Yeah, so we ask patients to hold their breath, and we also do some MRI, but a shorter version to better see the bile ducts.
Yeah, it's all about keeping the motion as minimal as possible.
So how long would a patient, I think you did mention this, Sally, how long would a patient typically be on the table?
Each session is booked out for about 45 minutes. They're getting the patient into position, taking the images. As Maria pointed out, you've got the nozzle, and then you've got the little flaps on the side that take the pictures to make sure that everything's in position. And then I'm not sure, I think possibly you wouldn't be expected to hold your breath for a whole 10 minutes. It's just breathe in, breathe out. But yeah, the actual delivery of the PBT is quite short in comparison to that whole 45 minutes. The majority of that is taken up with positioning, verification, making sure everything's, the anatomy is all in the same position for each treatment.
Thank you, Sally. I've just noted, Mark, you've got your hand up. Thank you.
Yeah, I was just curious. You're mentioning that the beam things move around you, but it looked like the bed that you lie on moves as well. So I'm guessing you're strapped down in a way. I'm just thinking because I know some patients find MRIs quite claustrophobic, so being strapped down would be quite bad. But I just wondered what does that happen, or is it? I'm kind of picturing a theme park ride in my head at the moment.
I don't think patients with liver cholangio would be strapped down. Maria can answer this. If you are having a treatment in your head and neck, or brain, then you would have a mask on that is strapped down to the table. Maria?
They are strapped down because we've got the abdominal compression device. So there is, so as Sally said, we make this sort of bean bag, like a special made mattress, which keeps you, so you can't sort of wiggle. And then we put this, which looks like a big corset on your tummy, which keeps you connected to this mattress. Now, when we move the couch, it's a very gentle, soft motion. So it's just like a very slowly raising, sort of like you might have on a sort of sofa at home where you can lie the sort of the back. So it's nothing's whizzing around, and that's why things take so long, because everything it's about trying, and we spend a lot of time, Sally mentioned, planning this. We need to find what's the most comfortable position in this awkward position, because we know the treatment hitting the tumor is important. And the reason we want to be so precise is that let's say if that couch is moves 5 centimeters, it means the bin stops 5 centimeters earlier, so it doesn't hit that tumor.
Thank you, Maria. And then just another question that's come out, and this may have been answered, but what size tumor is considered to be small? There might be one for Doug, Professor Thorburn.
So it's less than 3 centimeters. I quickly answer it too.
Yeah.
Okay.
That's correct. Yeah. Can I jump in with one question here, which is, again, sorry, Professor Thorburn, it's another one for you, but I think you'll understand why. It's important and reassuring to know that the service is based on evidence, but why do you think there were fewer tumor recurrences in the PSC group in the study you showed us?
Yeah, thank you for that. I think it also probably relates to why the protocol is directed to patients with PSC at the moment. So why is survival better? Why is recurrence less? And that's PSC patients. Well, some patients with PSC present and are found to have cholangiocarcinoma at the time that they present with a cholangiocarcinoma. Many of the patients that are treated or transplanted within the protocol are people that have been known to have had PSC and have been under surveillance and monitoring. So things were picked up at an earlier stage in the PSC patients than in people that weren't known to have liver disease and presented with so-called de novo cancer. So it would seem it's an issue of how advanced the disease is in the PSC patients versus the de novo patients. The reason that this pilot protocol is restricted to PSC patients is to see if we can target this intervention to the groups of patients where we think we could achieve the best outcomes. And that wouldn't mean that we couldn't transplant de novo patients without PSC in the future, but we would need to demonstrate that we could achieve these favorable outcomes in the PSC patients first. So that's, again, is dependent on the success of the protocol and the outcome.
Thank you for that. That's great. And Maria, do you see proton beam therapy being used for cholangios and other liver cancers in the future rather than other radiotherapies?
So at the moment in the UK, so I talk internationally, proton beam therapy is used in liver cancers, both hepatocellular carcinoma and cholangiocarcinoma. However, in the UK, the proton beam centers were built mainly for children, and we can treat adults only in a clinical trial or where there is evidence approved by NICE that proton beam therapy is beneficial. So for us to be able to treat patients with proton beam therapy, we can be only part of a trial.
Okay, so
And this applies to all cancers, not only for liver,
yeah.
sadly.
Yes, but when you think how expensive this machinery must be, it should be put to maximum use, shouldn't it, really?
So it's a very limited resource. So
Yes.
I'm not sure there is enough resource to meet the needs of the UK population. So at that present, I think 2/3 of the capacity is for children, and the rest of the capacity is available for research to gather the evidence to use it for the patients who indeed benefit from it.
So really, the outcome of the EMPHATIC study could be hugely important, for the future, not just for what we're doing now.
Correct, and that's why we are really grateful that we've been given this opportunity.
Excellent. Yeah. Paul, you got your hand up.
Thank you. A lot of the discussion that we've had this evening has been focused on a pathway where the patients have sort of had transplantation following initial presentation of their cholangiocarcinoma. So I was wondering if someone had a liver resection for cholangio several years ago and then they had a recurrence, would they potentially be eligible for a transplantation down the line?
No. Unfortunately, no. As Doug showed, the evidence we have, it's only on patients who present with cancer at the initial presentation.
Okay.
Thank
So
Yes,
carry on, Doug.
The only thing I would add to that is because I saw a question pop up about it, but if somebody had a liver resection of cholangiocarcinoma several years before, say, and 5 years later they developed liver failure and there was no evidence of recurrent cholangiocarcinoma, then that patient might be considered for liver transplantation for the indication of liver failure with a previously successfully cured cholangiocarcinoma. But if there would not be an option of transplant for cholangio if the patient had had previous treatment according to the way the protocols designed.
So had a resection, or if they'd had, long-term remission, no evidence of disease, having had targeted and immunotherapies and immunotherapy, but through all of that had really significant liver damage, could they be considered for a transplant?
Unfortunately, no. But Doug can say it's just because the cancer wasn't removed, so they haven't been cancer free. So what Doug was saying, that if you have a resection and that you're cancer free for 5 years, but the liver fails because, let's say, it's too small or something happened, then a transplant can be considered. But if the surgery was never an option and the cancer is sort of controlled, if it doesn't matter how long, we never know if there are cells behind or not, unfortunately.
Thank you.
Helen, we do have 1 minute left of the webinar. I know this could have been 2, 3, 4 hours.
Yes, because I'm just looking at the number of questions, but I do genuinely think a lot of the questions were coming in as each speaker was doing their presentation and have been answered. But Doug, Professor Thorburn has his hand up now, so just.
I just was wanting to also, and it may have been heard and made stated and I missed it, but one of the very good things about this commissioning evaluation is it's been supported by all 4 of the nations. So there might only be 2 treatment centres, but patients from Scotland, Northern Ireland, Wales are all eligible to access this protocol as well. So there should be equitable access to this nationally, which I think is a key, aspect, given we were talking about the cost of this therapy, but there's been a commitment shown to this across all 4 nations to support this, which I think is excellent. Thanks.
It is very unusual and excellent. Yes. Thank you very much. So I think that's probably a good point for us to have to stop. And I'd just like to express my sincere thanks to absolutely everyone who's taken part and this evening, and especially Professor Thorburn, who has done valiantly in doing 2 presentations. We're very grateful to our sponsors who have supported us in enabling us to do a series of webinars. And also thank you so much to everybody who's attended tonight and who's asked such really astute questions. Many of them, I would be asking myself, and I'm sorry if we didn't get round to your question. If you feel your question hasn't been adequately answered, then please do quickly email us. You can email us on info@ammf.org.uk, and we will do our best to pass the question to the most appropriate person. But yes, so I'll hand back to James for the final words.
Yeah, I just want to say a big thank you to all of the speakers, all of your time this evening, and again, reiterating what Helen said, for everyone at home, really appreciate it. I will remind everybody that the recording will be uploaded on the website, probably be a couple of days, but you'll get an update on social media, I'm sure, so please look out for that in the next couple of days. Thank you, everybody, and have a good evening.
Thank you very much, everyone.